Okay, so we're going to start with our first recording of the hematologic PowerPoint. We're going to start with sickle cell. This PowerPoint will be broken up into 3 different lectures. Okay. Hopefully this is review to you guys. Hopefully you can see this a little bit better on your other PowerPoints. I didn't realize it was showing up this badly. Erythrocytes or red blood cells. We know those are transporting for nutrients, oxygen, and waste products from the tissues. Thrombocytes or platelets are for clotting, and leukocytes, white blood cells, are fighting for infection. And then there's different levels of them. We got to remember that when looking at the possibility of hematologic issues in the pediatric population, we need to look at multiple different things. Those symptoms or assessment pieces that we might look at that could give us an indicator that they are having an issues would be things like fatigue, malaise, pallor of the skin, unusual bruising, excessive bleeding, or trouble with getting bleeding to stop, different things that would show that we're having clotting issues. We may have to look at multiple different things in each of our patients to figure these things out. All right. So assessment of the hematologic system, we're going to look at the CBC, their historical data, those physical assessment of findings, the children's energy and activity level, and their growth patterns. So we're going to want to do blood levels, and that'll give us an idea of what we're looking at, infections and things like that. Historical data, we can look at family history of issues. We can look at different things, growth and development of that child. Are they growing appropriately? Are there lots of periods where they are having slow growth? Is that patient having change in their ability to do daily activities of living, things like that. Those physical assessments, looking at their skin, taking their blood pressure, vitals, looking for bruises, looking for and asking for questions related to the bleeding and trauma that the child has had, whether it's a skin knee and what kind of things it's been like to stop that skin bleeding, growth patterns, things like that. So sickle cell disease, this is inherited disease where the red carry the normal adult hemoglobin. And we will get into more in depth on that, but this is kind of a unique picture. It kind of shows us the what the kind of the cells look like. All right. So, as your slide says, sickle cell anemia is an inherited disease. It occurs primarily in African Americans, but it can be seen in Mediterraneans, Arabics, East Indian, South Americans. 1 in 12 African Americans have the trait. It is a recessive trait, which we will get to that here in a second. All right, so sickle cell is a recessive trait, meaning that the child has to get the gene from each parent. So the parents are both either carriers, or one parent has the disease and another is a carrier, or both parents have the disease. Interesting enough, sickle cell was derived in areas of the world where malaria is common. They have found that the sickle cell trait has protected these people from the issues that they deal with if they contract malaria. So it's kind of a protective trait that was developed. Okay, so pathophys. So when we're looking at fetal hemoglobin, we know that, and we discussed this on our first day of class, that fetal hemoglobin has a lifeline of like 90 days. And adult hemoglobin is much more higher than that. We don't start typically developing adult hemoglobin until around 4 to 5 months of age. And at that point, that adult hemoglobin is what then starts turning into, as it dies away, it gets replaced with these abnormal hemoglobin S's. Okay, so one thing that babies have going for them is they don't have any sickle cell issues right off the bat because of the fetal hemoglobin that they have in their circulation. So as their body starts to develop these, and they may have some of this hemoglobin S in their circulation at birth, but it's very hard to find, and typically it's not developed, like I said, until 4 to 5 months of age. Okay, so what ends up happening when these hemoglobin S's are developed in the skin, or in the body, they are abnormally shaped. Okay, and so then you end up having these adhesions or entanglement or enmeshing of these cells within the microcirculation, which then, as we know, leads to vaso-occlusion. And so that can cause hypoxia, infarction, or ischemia to the tissues in that area. It can affect many different organs. It can impact your brain. It can impact your fingers, wherever the area is that the circulation is getting stuck in. Hemoglobin S also has a shortened lifespan compared to adult hemoglobin. Okay, so this is just another kind of contouring of what I was just talking about. So we can have those large tissue infarctions. Another place that we can end up having is the spleen. And what does the spleen do? You guys should know that. But think about this. What happens is the blood is trying to get out of the spleen, but because of the microcirculation being blocked off, the blood can't get out of there, so it pools. And that can cause many issues. Okay. It can result in immunity issues. It can cause these childs to have splenectomies and things like that. Okay. So this is a picture of all the different organs that could be affected by sickle cell disease. It also kind of shows healthy red blood cells there, and then the sickled cells in there, and you can kind of see it in that microcirculation. You can also see that it affects the brain, and they can have strokes. They can have blindness. They can have gallstones. They can have splenomegaly. They can have issues with their urine, their hips. They can have pain, painful erections, pain in the bones, ulcers, things like that. So how do we diagnose sickle cell? Oh, sorry, I'm jumping ahead. Prognosis for sickle cell anemia. There is no cure. They are looking at bone marrow transplants to see if we can get more healthy red blood cells in the skin and have less of these sickling cells being developed. So basically, it's all about supportive care, preventative care. These kids can also have a lot of bacterial infections. They could be immunocompromised. They can have... and the infections are what sometimes leads to death. Also, because of the blocking of the microcirculation, this could lead to strokes in the kids, but also it can lead to these kids having neurodevelopmental delays, cognitive impairment, poor growth. All right. So there are a bunch of things that can lead to sickle cell crises, and this is very painful to the patient. A sickle cell crisis can be caused by anything that increases the body's need for oxygen or alters the transportation of oxygenation. Okay. If you think about anything that increases the body's need for oxygen, so trauma, fever, infection, dehydration, stress, like nursing school. You guys are under a lot of stress. If you had sickle cell, that could cause you to go into a crisis. Lack of sleep, activity, hypoxia, being in airplanes, climbing in the mountains, hypoventilation, even hypothermia can cause the need for oxygen. And therefore, what's our body do when we need oxygen? We produce more red blood cells. But guess what happens? Instead of producing healthy red blood cells, they produce these sickled cells, and then that leads to the enmeshing and the crisis. Okay, so we have different types of sickle cell crisis. We have the vaso-occlusive that we have here on this slide. This is one of the most common types. It's very painful. As you can see from this slide, there's clumping of cells in the microcirculation. They can have fever, pain, and tissue engorgement. With this one, it's splenic sequestrian or aplastic crisis. The splenic sequestrian, this is the one that I was talking about earlier, where we can have a lot of problems with the spleen and the blood pooling in the spleen. This is one of the most life-threatening forms of a sickle cell crisis. They're going to have very profound anemia. They can have hypovolemic shock and issues like that. We do have aplastic crises. And that is when we have diminished production and an increased destruction of red blood cells. So they're not producing as many red blood cells, and these red blood cells are being destructed really quickly. So anemia, pallor. This can be due to infection, lack of folic acid. So kind of think about kids with sickle cell disease. It may not be uncommon for them to be on a folic acid supplement. One other form that crisis that we do not have listed on any of my slides is the hyperhemolytic crisis. It's similar to the aplastic crisis. The only thing is, instead of a diminished production, the body is producing blood cells normally, but they're having that accelerated rate of destruction. So they're still being destroyed a little bit faster than the production of the red blood cells, but they're producing them at a normal rate. So they will have anemia, jaundice. Okay. So how do we diagnose sickle cell anemia? All kids in the United States are screened with that newborn screen. We talked about a newborn screen in Care of the Growing Family. That's when they do that heel stick, and they're testing them for all sorts of different disorders. The newborn screen is just going to give us an indicator that there is a possibility of the child having the disease. It does not mean they have it. It could mean that there's a possibility. So it could mean they're actually only carriers. This is also what the sickle turbidity test is. It's a quick screening that just kind of gives us an idea that there's an abnormality. The child could be a carrier or could have the disease. To fully diagnose the disease in infancy, you're going to want to do a hemoglobin electrophoresis. The hemoglobin electrophoresis is what is going to distinguish between carriers and those having the disease. Okay, so it's going to look at the disease finger proteins. All the other tests are going to just tell me there's something off, but we can't tell if they're a carrier or if they have the disease. Hemoglobin electrophoresis is going to be the only one that's going to tell you that they actually have the disease and they're not just carriers. Okay. Once the child starts developing adult hemoglobin, they could actually do a red blood cell smear and actually see the abnormal cells. But once again, that's not going to happen until they're a lot older, because we won't be able to see those abnormal cells until they're past the 4 to 5 months of age. Okay, management of sickle cell disease. So we're going to want to prevent sickling. So preventing the need for oxygenation in the body. We're going to maybe give them folic acid. We're going to give them blood products as needed. We're going to up their diets so they have lots of iron and different things in their diet. We're going to make sure that this child doesn't get sick. So we're going to make sure they get their vaccinations. These kids, it's not uncommon for them to also have prophylactic antibiotics to help prevent infections. This could be done by IM injections or orally. We're going to do regular red blood cell counts and reticulocyte counts, seeing how they're producing red blood cells. I mentioned blood transfusions. We can do exchange transfusions. Exchange transfusions is when you take out so many milliliters of the baby's or the toddler's blood or the child's blood, and then you put back in donor blood. A partial exchange transfusion would be, once again, taking out so many milliliters or cc's of the child's blood and then replacing it with saline. Basically, what that is doing is diluting out the abnormal cells. Diet, good nutrition. If needed, the splenectomy, get rid of the spleen if it's having problems. Remember, with kids with sickle cell anemia, they don't bleed out. When bleeding occurs, they produce more red blood cells, and therefore they clot. And the blood then slowly trickles to that area, and then it becomes ischemic. It's not like hemophilia where they bleed out in injuries, okay? Okay, so more management of their care. So monitor the growth and development. Watch for them, the failure to thrive. So we're going to do good follow-up with these kids, making sure they get to their regular appointments, making sure their diet is well established, doing that full head-to-toe assessment and seeing if we're noticing any abnormalities, assessing and treating their pain. Sickle cell is extremely painful. One of our big things with sickle cell disease is to treat the pain, okay? The ABCs of pain management is really important. So A, for the ABCs of pain management, A, assess the pain. B, believe the pain. C, look for complications or the cause of pain. D, use drugs and distraction for the pain. E, make environmental changes. Okay, so turning down lights, things like that to decrease the stress. F, give fluids, hypotonic type fluids, D5, D5W, things like that. Okay, so ABCs, assess the pain, believe the pain, look for complications or cause of pain, use drugs and distraction, then make environmental changes, then give fluids. Okay. And then we want to do antibiotics, blood replacement. Okay. Oxygen. Something to think about with oxygen. If the child is not hypoxic, oxygenation would be bad. If they are hypoxic, then we can give them oxygen. If they're not hypoxic and their blood levels are like, their blood oxygen level is like, let's say 88, 89 to the 90s. If I were to put oxygen on that child, it actually may suppress the bone marrow production, which then will increase anemia. So we don't always give these kids oxygen because it could actually make the situation worse. So if they're hypoxic and showing signs that they need oxygen, then we will give them oxygen. All right. Psychosocial needs. Helping them cope, helping them see why they're different, helping them deal with missing school and not being around their peers, helping them maintain as much of a normal life as we can. These kids will they will want to be in sports. They'll want to be doing things like that. They can be in sports, but we may have to be careful. We may want to be in things that aren't going to cause as much oxygen demand. But if they can afford it and their child really wants to be in sports, they will do it, but they need to have lots of rest periods. They will have to be followed closely by their doctor to make sure the stress in their system isn't causing them a lot of sickle cell issues. Okay. Genetic counseling. A lot of the times the parents don't even know they're carriers, so we'll need to do genetic counseling that way. Genetic counseling with that child as they get older to see if they can make the decisions on reproduction later in life. Financially, this is a huge toll on the family, going to doctor's appointments, medical appointments and treatments and things like that. So we will want to make sure we're getting the multiple disciplinary team involved. Social workers, anything we can to help them with the finances. Caregiver role strain. We're going to help those parents with whatever stress level they're dealing with related to the child's treatment and how the family can deal with it. We're going to help the family go through counseling if needed, help the family talk about what they're feeling like. We're going to involve everybody in the child's care. We even do things for the siblings. So while the child is in the hospital, we may actually have a child life specialist or people in the hospital that will come and spend time with the siblings so that they feel like they are also being cared for during the child's hospitalization. So it's really this unique role of things that we do for these kids. All right, that's the end of sickle cell. And then the next PowerPoint will be over HIV.